Today's August 13th, 1997. We're in Missoula, Montana. We're at the 1997 Valve Symposium, sponsored by the International Heart Institute of Montana, hosted by Jim Oury and Carlos Duran. The first lecture tomorrow morning will be given by Mr. Donald Ross, and he will discuss the development of cardiac surgery and the pulmonary autograft for aortic valve replacement. Mr. Ross was born in South Africa. He graduated from the University of Cape Town Medical School in 1946. He obtained his membership as a Fellow of the Royal College of Surgeons in England in 1949. He spent most of his life as a cardiac surgeon in London, first at Guy's Hospital and later as the senior surgeon at the National Heart Hospital. He is known throughout the cardiac surgical world for his pioneering work in developing the pulmonary autograft for replacement of the aortic valve, an operation now known as the Ross procedure. He was the first to perform this complex procedure in 1967. I'm going to ask Mr. Ross to tell us about the development of this procedure. But first I want to ask him to start with his childhood growing up in South Africa.
Well, as you said, I was born in South Africa, and I think I still have a South African accent. Some people think it's Australian, but it's South African, and I'm proud of that. But my parents came from Scotland, both of them. My father from Glasgow and my mother from the Highlands of Scotland. And really they got out of Scotland because it was cold and slightly miserable, and they were poor, especially my father, who worked in Glasgow in the Clyde, in the shipbuilding area of Glasgow. And I think he was wise to get out, because I visited it with him subsequently, and I must say it was a hard, struggling life in Glasgow. And so he, like some other people, his brother went to New Zealand and he went to South Africa to make his new life. And my mother followed shortly afterwards from the Highlands of Scotland. They remained very Scots-orientated all their lives. You know, my mother's accent was so strong that sometimes they used to have to get someone on the phone to come and translate for them from the Scots into the English. Yeah. My father, Glasgow, they were the lowlanders. They're much more easily understood than the Highlanders. And they tried to make a Scot out of me in that they sent me over to Scotland for 2 years. I went to school there, sort of preliminary school.
What age were you?
I must have been about 6 or so.
Oh, that must have been hard.
Yes, I didn't like it very much. It was too cold coming from South Africa. But, you know, they sort of, I suppose, thought it was right that I should be brought up to some extent with my grandparents and see what it was like where they were brought up.
Yes.
And we went, you know, I came back gratefully and went to school in Kimberley in South Africa, but it was...
Kimberley was your home?
I was born in Kimberley, yes. I had 4 sisters, as a matter of fact. They were all born in Kimberley. And we lived there for the rest of my father's life anyhow.
What work did your father do?
He was in the shipyards in the Clyde.
Yes.
And was a handyman, I think, a sort of, they called them joiners, but very handy with his hands, really. And when he came out to South Africa, he started a business in Kimberley, in sort of light engineering business, and became very well known for his ability to mend guns, mend machinery, and so on. Developed quite a good engineering business there. But, you know, those were the days of the Depression.
Oh, yes.
It was a really hard life. I remember it well. And we didn't, you know, we had everything we wanted, everything, and it was good life in South Africa, basically, but it was a hard life. And the Depression years really made quite a mark on my conscience and my memories.
I think it did everybody that grew up at that time.
Yes,
The
that was the
Depression had
days.
profound
39, I think.
influence on the rest of their life.
1929 onwards, I think. I
Yes.
remember.
And-
That was nice.
And you then went to the University of Cape Town
Yes. Oh, well, I went. My schooling was all in Kimberley.
in Kimberley.
And in it's called the Boys High School, and it was an excellent school in that it was, you know, it was the emphasis was on the classics, Latin and mathematics and things, which was usually successful from my point of view in that I really wanted to learn about these things. But South Africa at that time was divided into, it was a complex country in those days. The division was between the white people, not so much the whites and the blacks as it became subsequently, but the white people were divided among themselves into English speaking, which was me and my parents, and the Afrikaans speaking, which were the descendants of the Boers. And the Boer War was still fresh in people's minds those days, you know, and there was a hatred and rivalry still present, which has now been subdued, of course, because they then got a common enemy in the black people. But when I was brought up, we were an English-speaking school as opposed to an Afrikaans-speaking school, and so on. The white people were strongly divided. Now, yes.
Did you speak Afrikaans?
Oh yes, everyone. I'm totally bilingual still. It was a waste of my time, I must say, but I can still speak Afrikaans freely. It's the same as Flemish, in fact. Not much use to anybody really, and it's very seldom spoken now, or much less spoken now. It used to be almost the premier language in South Africa. But the universities were also divided, you see. Cape Town University was an English-speaking university with English traditions and professors out from Scotland and so on. Excellent.
See, yeah.
But Stellenbosch, 30 miles away, was the Afrikaans-speaking equivalent. Same as in Johannesburg, there was the Witwatersrand University, the white-speaking, English-speaking white university. And Pretoria was the Afrikaans.
Oh, I see.
University.
And they had two medical schools also. Stellenbosch had a medical school as
Yes,
well as
and
Cape Town.
Johannesburg and Pretoria.
Yes.
Now there are lots of medical schools, and of course those distinctions are obliterated now. Between the whites are all together now, virtually anyhow, and the black people weren't allowed into the universities when I was there. Really, there wasn't any openings for the blacks.
What led you to a career in medicine?
I don't know, except that, I like to be, I've always wanted to make models, radio sets, and I've always been an inquiring mind and wanted to use my mind and my hands. And I suppose I thought that's really what I got into surgery, why I got into surgery. I thought medicine was a fascinating subject, and I did the so-called Latin and things that you had to do, we thought, to become a doctor, and subsequently obviously that you didn't, you'd be able to be a scientist. But yes, I think I wanted to get into medicine. It was fascinating, but I also wanted to be able to use my hands. And
Was medical school at that time difficult to get in and difficult?
Yes, very competitive.
Very competitive.
Very competitive.
Right.
And they got about 200 entrants every year into Cape Town University, and about 80 would end the first year. To go on. The others were eliminated straight away.
Eliminated, a bad system, right?
On the first, yes. It was competitive to get in and competitive to stay in, really.
Yes.
It was.
And you graduated with the highest honors.
I got the gold medal, as they call it.
Yes. And then did you go on to internship there?
Yes, it was part of your requirements that you had to spend at least a year in the university before you went out into general practice, into the country. And so I was in Groot-Schuur, yes.
At the Groot-Schuur Hospital?
Yeah.
Yes.
Which was our teaching hospital. And the interesting sidelight to that is that, of course, Christian Barnard and I qualified together and we spent 6 years in university together, and then we spent another year as, doctors together.
I knew you must have known him, but I didn't know you were in the same class.
Yes.
Yes.
He was a good boy those days.
I'm going to ask you about that later, because I want to know what you think happened. So after your first year, then you went to Bristol at what time?
Well, I went, after a year, I won a scholarship when I graduated. I won a scholarship, overseas scholarship for 2 years. I think it was called the E. Oliver Ash Scholarship or something. A Kimberley-based scholarship, I think. And so I decided to go to England and do my fellowship at the Royal College of Surgeons, if I could, within 2 years, and come back and practice in South Africa. Well, I got to England, worked hard and got the fellowship at the Royal College of Surgeons within my 2 years, but by then I was launched sort of in England, wanted to stay there for a while because surgery was so exciting at that time. But I never planned to stay permanently there. It's just happened.
I see, yeah. You plan to go back?
A lot of people thought, I wanted to get away from South Africa, but it wasn't at all. It just happened that way, and my career developed in that direction. I had to stay.
And those 2 years were in Bristol?
Well, when I'd done the fellowship, I was in London to do the fellowship. That took 2 years. There's a primary fellowship, and then you have to do a period of time as a practicing junior before you do the final fellowship. And so I did the primary fellowship in London, then went down to Bath, where I worked under Dr. Kindersley there, who was really, he had the pride was to get his boys through the fellowship, which I was lucky there. And so then having done a year in Bristol, in Bath, beg your pardon, where I nearly turned to orthopedic surgery because I worked for an orthopedic surgeon there. And then I went back to London, did the final fellowship, and got a job in Bristol because the Bath and Bristol are about 30 miles apart. The Bath people handed me on to Belsey in Bristol because by then I decided, yes, I wanted to try and get into this chest surgery, which was developing into cardiac surgery. And so I went to Bristol, worked for Belsey, who really opened the international scene to me. He was well known, developing his Belsey operations, the Mark I, yes. Mark II, Mark III. I was through all those. And we had a lot of fun together. He's and still is, a very intelligent, bright man, very interested in hunting, fishing, and shooting. And he tried to turn me into a country gentleman, and was unsuccessful, I must say. But we used to talk over operations, and I'd say, why don't you do this, why don't you do that? Because we got on very well. He'd say, well, if it works, we'll call it the Belsey procedure. If it doesn't, we'll call it the Ross procedure. And those we had a good relationship.
Those were esophageal procedures primarily?
Yeah, mostly esophageal, but we did a lot of tuberculosis work, thoracoplasties. Yes. That was before resection even.
And that was because there was so much peptic esophagitis? Is that right?
Well, he had such a reputation for it. I mean, people really came to him. He did some of the first, these little baby things, esophageal...
The atresias.
Atresias. They used to not fly them in because they weren't flying those, but they used to come by ambulance from all over, esophageal atresias for him. And that was his great excitement and a great...
And then you mentioned tuberculosis.
A lot of tuberculosis.
What sort of procedures were you doing for tuberculosis?
Well, we were doing things like phrenic crushes, I used to go out to sanatoriums and do a morning full of phrenic crushes and a division of adhesions and things.
How long would that phrenic crush? I've always been curious about that because a lot of them regenerated, didn't they?
I think a lot of them weren't crushed properly.
I see.
And a lot of other things were crushed, like baker's nerves and things.
Oh, I see.
I think that was it. I think if you crushed the phrenic properly, it was crushed all right.
I've never understood that. Yeah, you would think that would not
It
regenerate.
was a nice little operation.
Yes.
But then we did thoracolplasties, under local anaesthetic. These taking 9 ribs out of these mostly young women, It was tragic. You used to go to these sanatoriums and visit the sanatoriums, and these people were just waiting for the doctor to arrive.
And that would be a patient that had cavitary tuberculosis that was still sputum positive.
That's right. And
the thoracolplasty would close the
we
cavity.
did the upper 3 first,
Yes.
and usually the senior surgeon would do that, and then the next 7 ribs or whatever it is, I would usually do that.
And what interval would it be between those?
Can't remember that, to be honest. I think some months anyhow,
Yes.
probably. But that was
And
hard
the
work.
instability of the chest wall, did that produce respiratory insufficiency in any of those patients?
I wasn't aware of that.
Yes.
It was so solid, the lung was so fixed by then.
Yes.
No, I'm not aware of that at all.
Right.
But it was a horrible, mutilating operation. I mean, it was such a pleasure when resection came in.
Now, when was that? When would that be?
That was sort of at the end of my period with Belsey.
Yes.
And arguments were raging then about whether you could resect, but it was streptomycin that, of course, turned the trick.
And that would be in the early 1950s.
I guess so. And that's when Belsey handed me on to Brock, and because he knew I was excited about this prospect of cardiac surgery, which was just coming through in the Lancet, the pulmonary valvotomy, the Blalock operation, these things, and Brock was the one who was doing it in England. And Belsey took me, he was a great sports car enthusiast, with his Aston Martin. We drove to London. He took me there to see Brock do an aortic valvotomy, a closed aortic valvotomy.
Wow.
Closed aortic valvotomy. And I was going to tell him about it tomorrow. That was, he stuck this thing in the aorta and blood everywhere. And I thought, this is fantastic.
You thought it was fantastically interesting or fantastically
oh, wonderful!
bad?
That's a real no, fantastically interesting, and that's a real research. So that's when I became, and Belsey then sort of got me a job with Brock as his research fellow. So I did research for 2 years, and then got into.
And that would have been 1954, would you say?
52 to 54, around about there.
Right.
Then I got a job on the staff at Guy's, well, as a senior resident, then.
Well, that must have been a very interesting time.
Oh, it was fantastic.
So
we were doing a lot of research and surgery at the same time. It was all sort of developing like that. Lily High was busy making heart-lung machines and doing cross-circulation.
Now, who was that?
Lily High.
Oh, yes,
Yeah.
Dr. Lily High, right.
That was really exciting time.
And Lord Brock then was doing valvotomies,
Yes.
pulmonary valvotomies.
Yes.
He was doing Blalock shunts.
Never took to it, really.
He didn't?
No, he couldn't, too fiddly. He liked to punch the things, in pendicular resection and valvotomy and whatnot. He never really, it sounds disloyal, he wasn't really very dexterous. He liked to do direct surgery and very rough sort of surgery, rough in inverted commas, but
That's interesting.
he didn't like to fiddle around with Blalock anastomoses. He never really got happy with heart-lung bypass surgery. We used it certainly, and we all developed it there. But he, for instance, his ambition was to do fallow total corrections, of course. But he had a lot of trouble with, closing the VSD and things like that. Well, we all did, but he was never as dexterous as Kirkland and Lily High and these people. And he used to get so cross, frustrated by his inability to achieve things, and he used to give us hell. He gave us a bad time.
I see.
Why doesn't somebody help me? And we knew we could do it just as well, or perhaps better. There you are. That's life. He taught me a lot. I mean, what a brilliant, incisive mind. But as I say, didn't have the dexterity that he would have liked to have had.
Yes. Now, you mentioned the early use of the heart-lung machine. Was that a machine that Dennis Melrose developed? Or
Well, no, that was, he was developing it at the same time.
What
And
sort of
that
device?
was, we called it the butter churn. It was a sort of a
butter churn.
great turning thing with the blood.
That was the first heart-lung machine at Guy's Hospital?
No. Well, there was a rivalry there between the Hammersmith Hospital, where Melrose was developing that,
I see.
and Guy's Hospital, where Brock and he didn't see eye to eye, really. And we opted for I'm glad to say, hypothermia first. We were sort of pioneers in hypothermia there. And then from hypothermia we started on cross circulation, but never did it clinically, I'm glad to say. And then from there went on to Lilly High's, sort of opted for Lilly High's bubble oxygenator.
I see, yes.
Fortunately.
Yes.
And the Melrose was sort of a little bitter and disappointed that it was really the first British heart-lung machine, but we didn't. We made our own rotating disc oxygenator in Guy's Hospital in the workshops there, but not the Melrose one, no. He certainly did a lot of things. I mean, he used the potassium for the heart. That was his striking application to cardiac surgery, Melrose.
That was both a good thing and a bad thing, wasn't it, the potassium?
Yeah,
because
I think it did a lot of harm.
wasn't it?
Yes, we did a lot of harm with it.
Yes,
We
right.
didn't know how to use it. We were trying to stop the heart, you see, and get on with what we were doing, but we weren't supporting it at the same time properly. No, it was a bad thing. We
Yes.
overdid it. Yeah.
So you went through a phase like in the middle 50s then of doing hypothermia and inflow occlusion
Yeah, a
and
lot
doing
of that.
open valvotomy then.
Yes.
You would do an open.
Oh, yes, indeed. And
pulmonary valve?
ASDs and
Yes.
yeah.
Wow, that.
And we tried, aortic, that was hopeless.
Yes.
Because like Mount Everest, we realized you had to use open heart surgery for that. But mitral valve surgery, it was all closed. Brock was one of the international leaders in closed mitral valvotomy. Brock, Bailey, and Harkin.
Yes.
Sort of vying for who was the best. But that wasn't very exciting. We really wanted to do open surgery.
And so you went through a brief period where you intended to do cross circulation.
Yes, we did it in the dog lab quite a bit, but didn't. I went on doing dog surgery all the time I was doing this.
And then you first used the bubble oxygenator then to do open procedures. What kind of open procedures would you say were done? Were they more congenital? Or
mostly congenital.
Mostly
There was a
congenital.
big backlog of congenital work needing doing,
Yes.
particularly ASDs, AV canal. We discovered really the problems of AV canal, and yes, I would think that was mostly congenital work.
Yes.
Because we didn't have valves, we didn't have any sort of valve surgery.
Now, I read your comments about the first homograph valve, and that you were doing then some decalcification of the aortic valves. Tell me about that.
We developed our heart-lung machine to our satisfaction.
Which was a disc oxygenator,
yes,
rotating disc
that's
oxygenator.
right. And we were still carrying along with the bubble or developing the bubble, but the bubble, everyone was suspicious of bubbles, but of course they've proven their worth. And I was developing an increasing interest in the aortic side of the heart. And we did decalcification. I was doing decalcification procedures. Brock let me do them, and most of them did very well. I mean, better than nothing, in other words.
And that would have been in the very early 1960s, would you say?
Yeah, end of 50s and beginning of the 60s, yes. And we were, at the same time, Brock was interested in blood vessel replacement, you know, for coarctation segments and for abdominal aneurysms and so on. So we were collecting tissue segments, I mean aortic homograph segments, but we were collecting, I used to go to the PM rooms and collect whole aortas, and we were also collecting ascending aortas with the valve attached and cerebral vessels, and working out methods of storing them. This was the days before Dacron, blood vessels. And we would have to take them and put them in Ringer's solution, and they would, you know, go bad, and put them in the refrigerator. Then we'd developed formalin storage of vessels, balanced or formalin anyhow. It was, turn it into nasty sort of leather. And we struggled with all these things, and that was one of my side interests, was to develop methods of storing blood vessels, and we got into ethylene oxide and freeze drying and so on. And at the same time, we stored segments of aorta with the aortic valve, and I had a little pulse duplicator to try and make the aorta, see how long the aortic valve would last in a pulse duplicator. And parallel with that, Gunning and Duran in Oxford were working on the problem of replacing the aortic valve in animals, and they made significant contributions there, and we were all in touch with one another, and they felt a bit frustrated that they didn't have the clinical supply that I had, because by then I was getting well known for decalcifying aortic valves, and we had these segments of aorta and aortic valves freeze-dried, ethylene oxide sterilized and freeze-dried in tubes. And strangely enough, 40 years later, I think it's about, we found some of these in the lab not so long ago, and we could still reconstitute them, you see, 40 years later.
Preserved for 40 years, yeah.
But and I think that's something we've sort of, we should still be thinking about storing things by freeze-drying, especially perhaps for wartime, or you know, they're not perfect, but they're very serviceable, and if there's nothing else to put in, you put in a segment of freeze-dried aorta.
And so they didn't have to be taken under sterile conditions then?
Well, first they used to be, in the early days, before we knew how to sterilize and whatnot, but no, then we were putting them in formaldehyde or ethylene oxide or whatever, and so we were storing them, sterile, but very reactive, nasty calcifying tissues.
Yes.
But there was a famous day when, when I decalcified the valve and the whole thing disintegrated, and there we were with no valve, and no valves in England. No Star was just starting to describe it in 60, I think, or 61.
Yes.
We didn't have any. This valve disintegrated, and that was either the patient was going to die, or we thought of just one of these freeze-dried valves.
Your description of it is the valve went down the sucker.
Yeah, that's right. It disappeared.
It disappeared down the sucker.
Yeah, it disintegrated and disappeared. And so we knew about this work that Gunning and Duran were trying to do in dogs, was trying to sew in the valves, and so we reconstituted one of these valves and sewed it in just with a single suture line, expecting to have to send a telegram to Boeing or to Star to send one of these valves over, you see. And this we thought would hold the situation. Well, it did, and 3 months later it was still holding it and so on. And that was how we started on the homograph. It's great excitement.
The first homograph then really was not planned.
No, it wasn't.
But it was out of desperation.
Yeah, that's right.
That's very interesting. And so that patient survived for how long?
I think about 3.5 years or something.
Yes.
It was he was a sort of an end state. You can imagine those days if you had to come to cardiac surgery, it was like, either leave him alone, or if there's a 2% chance, try cardiac surgery. And that's the sort of stage of the disease we were dealing with.
So,
he did very well, I think, for 3 years.
so that led you to do others then?
Oh, yes. Then we refined the techniques and, you know, the different methods of storing, and it's still an argument about how's the best way to store a homograph.
Yes.
And but we started putting a lot.
And you used
the whole country flooded
you changed your technique to
double suture line.
yes.
Yeah.
And you changed your preservation technique to fresh homograph.
Yes, that was Barrett Boy's influence, really.
Yes.
Although we did, I had a very clever research lady working for me then from Iraq. She was Dr. Jalabi. We used to call her Jelly Baby. And she could, you know, do anything with tissue, could grow it, cultivate it. And she did a lot of work on sterilization techniques, viability studies, which are really cropping up now. She was doing viability studies. She did freezing techniques many, many years ago, long before the present cryopreservation excitement. She stored tissues in frozen and in glycerol. You know, she used glycerol as a cryopreservative and all that. So we were using all the available techniques at that time, but basically freeze-dried and ethylene oxide for a long time. Then we just froze them and stored them frozen. And then we used some in Ringer's solution, but Barrett Boys with his technique appealed to us, you know, storing them in tissue culture medium with antibiotics, relevant antibiotics, and our bacteriologists got excited about it, and so we stuck to that. In fact, I still preserve tissue in antibiotics and tissue culture. I think it's better than cryopreservation.
And so you'd use them up to about 6 weeks?
Yeah. Well, this lady did all the viability studies for us and could show us that, you know, they start off at about 70% viable, and that's the same with cryopreserved tissues. And over the next 18 days, there's practically no change in the viability done with tritiated thymidine. And then at 3 weeks, they started falling off. But we said 18 days to 21 days was the correct time, but, you know, you'd get pushed and there wasn't enough valves, and you had to, rather than let them go, you use them up to 6 weeks, and they seem to do very well. But I still think 3 weeks is the optimum period.
And what antibiotics were they?
Well, that was a great argument. You know, we overdid the antibiotics to begin with, as you can imagine. And Barrett Boys had one formula. We had another formula. Magdy Harefield Hospital had another formula, and so on. But it's not really. People used to come and say, "How do you do it? You know, what's the formula?" The formula is it depends upon the dominant organisms in your collecting area. I mean, we got ours from cadavers, you see, and the London cadavers, bacteriological flora is different from the ones in New Zealand and different from the ones in other countries. It was difficult to impress upon people that they had to formulate their own antibiotic.
I didn't know that.
Yes, that's very important. Yeah. And it still applies, of course, because organisms get wise and cleverer, and antibiotics get better, and so on. And
now, your first Pubbany autograph was 1966 or 1967? 1967. Yes.
Yeah.
Yes. We were talking about the first autograph.
Yes.
And how that came about, the circumstances. I think the circumstances of the first homograph was really interesting.
Yes, they weren't so dramatic for the autograph, because the autograph, by the time we put the first homograph in 62, I think it was, and within 5 years we were starting to get, there was great excitement, you know. At first when we put the homographs in, we thought they're going to be rejected, and we used corticosteroids and whatnot, and our immunologists got excited about it. Anyway, so it turned it was more dangerous to use immunosuppressives and get infection than to ignore the immunological reaction, which seemed to be peak at about 3 weeks and then decrease. So we gave up immunosuppressives. But it's sort of coming back into focus again nowadays, the dangers of rejection. But when we used Homographs first, we were very excited, and people were excited, the whole world, and his uncle came to visit and to learn about Homographs. And we thought we had the perfect valve, you know, it was wonderful. But around about 3 to 5 years, we started hearing new murmurs, diastolic murmurs. We started to get acute failures, tissue failures, tearings, and so on. And really, we were starting to get very worried about the long-term outlook for the homograph when we would take these valves out and study them under the microscope, see they're totally acellular. The structure was often well retained, the collagen structure, but totally acellular. And it's obvious to you and to me that the only reason our tissues survive is because they're viable cells to replace their matrix, their content. And so it was clear the writing was on the wall. And within 3 years, when everyone else was still just getting into homographs, it was clear to us the writing was on the wall that these valves were not going to be what we had hoped to be, permanent valves. We anticipated that they would be repopulated, you see, by the patient's own cells, yes. Which is still intriguing to me that they don't get, you see, because even Dacron gets repopulated. But it's the something in the tissues of the homograph tissue which won't let it repopulate. And so we were getting primary tissue failure.
And that was not so much calcification.
No,
but it was just weakness.
Yes, decellularization, yes. And lack of replacement of collagen. And so we realized something had to be done, and there were only two prospects really, either to use homovital, you know, living tissue. We were using, we thought, viable tissue, but slightly viable, but like kidney transplantation, heart transplantation, fresh, viable, truly living tissue with immunosuppressives, which of course negates many of the advantages of your homograph. It's like going to mechanical valves and having to have anticoagulant. So that was the one alternative, vital valves, viable valves with immunosuppressive, or autogenous tissue, living autologous tissue. And I mean, we tried pericardium, making valves out of pericardium, of the patient's own pericardium. Doesn't really function. And we had a long series, starting with the Leeds people, I think, yes, taking fasciolata out of the thigh and making the valves on it and saying what's it. And they don't really work. So the other alternative was your own tissue, and that's a key requirement. It has to be not only your own living tissue, but it has to be the same structure. And the aortic valve structure is very unique with its 3 layers. And so I believe then, and I believe still, that you can't simulate an aortic cusp with pericardium or anything else. I don't think it's going to ever work, although it sells well, pericardial valves. But the structure, the spongiosa layer and the ventricularis layer are so unique with the ability to stretch and have strength, and stretch radially and circumferentially, that you can't simulate it with anything else. So we realized it had to be another aortic valve, and you haven't got another aortic valve, or like you've got 2 kidneys, but you've only got 1 aortic valve, but the pulmonary valve is identical, or seems to be identical. Superficially, if you look at it, of course, it looks like a thin, filmy structure, and it'll never work. But there was some work by Shumway's group Lauer and Shumway, in showing that they could put pulmonary valves, dogs' pulmonary valves, into the descending aorta, and that they would, you know, thicken up and look as though they could work. And that was some information which we didn't have at that time, but it sort of seeped through that the pulmonary valve was something you could really regard as a possible replacement. And also, if you argue logically, the pulmonary and aortic valves come from a common truncus and develop together, and then the truncus divides into two. The one is the pulmonary, one is the aortic, but those tissues are identical initially and structurally identical and develop under the same head of pressure in the fetus, high pressure. So it's logical to use the pulmonary valve, and so we thought we'll have to put the living pulmonary valve in the aortic position, because that's the important side. You don't die from pulmonary incompetence, you die from aortic incompetence. And so that's one thing, to do it, to say it, and to reason it, but to do it was another business matter. And by then I suppose I was sort of confident and cocky, and we decided, after some considerable thought and deliberation, to go ahead and do it without doing animal experiments on it. In fact, one of the things that held up open heart surgery for a while was the feeling that you had to do it in dogs, and dogs are notorious. I mean, it's much easier to get a survivor in a dog, in a patient, than in a dog. And I remember Cooley once saying that. People were saying, "But haven't you done, you know, so many dog experiments?" He said, "No, dogs die." And anyway, by that time we'd had a lot of experience of putting in valves, and you know, the difficulties of putting in a subcoronary homograft. So we didn't think it was going to be difficult to put in the actual technique of putting in a valve, pulmonary valve, which was the same structure. Wouldn't be difficult to put it in. It's just a question of whether it would stand the acutely induced systemic pressure. So anyway, I can't even remember the day we did the first one, but we sort of stood back and waited for it to tear, but it didn't tear, and it never has torn, ever, as far as I know.
And of course, the first one would have been a subcoronary.
Oh, yes.
And then you used a homograft for the pulmonary valve.
Yes, we used an aortic homograft and a subpulmonary insertion.
Then another question occurred to me is, at that time in 1967, did you use coronary perfusion? What sort of myocardial preservation did you use?
Those days we used to perfuse the coronaries,
yes.
And that would make all, well, that's all all our aortic surgery was done with the beating heart.
Yes.
And it's very easy to get into the, you know, into the rhythm of it, a beating heart. Magdi Yakub still does it every now and again to show off and show, you know, to impress people, and they are very impressed.
Yes.
And I suspect that's one of the best methods of preserving the myocardium still, of course.
Yes, of course.
We use cardioplegia now, but I mean, nothing fancy. We just use it through the coronaries. And don't use retrograde cardioplegia either, but that's another story.
Yes.
But no, we did it then, those days, with beating hearts and subcoronary insertion. For the first 271, I think I did, were all
were done with cardioplegia.
Oh no, all done subcoronary.
Subcoronary. Yes.
No, I don't know how many were done with beating hearts.
Yes.
But when cardioplegia seemed safe, we switched to that.
And then the long-term results of those has proven to be very successful, hasn't it?
Yeah, well, I think the first chap is still alive.
It's pretty successful.
30 years.
The first chap,
more than 30 years. 30 years ago, yeah. He was last year, anyhow. So I presume he still is. So it's, yes, long-termly good.
Well, now, also I read one of your early articles about the ups and downs of heart transplant. You did the first heart transplant.
In Europe,
England.
yes.
Or in Europe.
Or something like that, in England, certainly.
Tell me about that.
Well, that was exciting because, you know, Barnard, who's my buddy, and he used to go every year he was working in Cape Town then and doing really good surgery. You know, he did some of the best fallow results in the world. And he was really a top-ranking surgeon, cardiac surgeon. And every year he went to the States to go and visit these meetings and whatnot, just as I feel, I still do, that I feel that I've got to go to the States at least once or twice a year to keep abreast, you know, talk to your colleagues and keeping abreast. And he used to come through for two reasons. One, he used to like to say hello to me in the heart hospital, but also the nurses in the heart hospital were very pretty.
He had a weakness there,
yes,
didn't
he used to take them out a lot. And he'd come in and nosy around while I was doing my surgery and say, why did you do this or that and the other? You know, we were great friends. And I remember him coming through one time on his way back. He said, you know, I've been watching Shumway's people doing a transplant, a dog transplant. He said, God, I'm going to do that. I still remember him saying it. And so we chatted about this, that, and the other thing. And then I forgot all about that episode. So we were doing dog work, transplant dog work, like everybody was. I mean, everyone knew you could transplant hearts. It's not a difficult or big operation. It's just a question of no one had done it in humans, and we didn't have really immunosuppressives and anything else. It was a technical exercise we were doing in dogs. And in fact, Brock made some contributions to the technology of heart transplantation. So we were all about the same level then. Shumway, we knew, had the biggest dog experience, biggest experimental surgical experience, and was really putting it on a scientific basis. And my friend Chris went back to Cape Town and obviously determined he was going to do it. And I remember arriving in South Africa to some reporter saying, when do you think we'll do the first heart transplant in this world? And I said, oh, I think within the next few years. Anyway, the next month he did it. You know, that's the way it is. And that sort of was the beginning of a great excitement. We all, of course, then all you needed was someone to light the match, and we all aflamed, and we started doing, I think, prematurely, and but it was an excitement like which I've never known in surgery.
Yes, I think that's true, for not just in surgery, but also, of course, for the media and everything else.
Oh, yes, I mean, the papers were full of it. Barnard's face on the Time magazine.
Yes, I'm sure Dr. Barnard didn't anticipate that.
Oh, no, he didn't.
I don't.
And but that was the end of his surgery, really.
Yes,
the media took him over.
Yeah, why do you tell me about that?
Well, he was taken over. He was turned into a playboy overnight, and he's never looked back. I mean, he really never did anything useful after that again.
Yeah, that's so tragic, I think.
And we went to, you know, I was caught up in this excitement of having done a transplant, and the chap was doing well and whatnot, and we used to go to meetings together. The media were all over him, and he was the success of the century, really.
I guess it's...
But that was the end of his surgery, really.
Yes.
And I can't blame him. I mean, he got married a beautiful lady, and he got a lot of money, and was in the news all the time. Now he's sort of settled down at last.
Where is he now?
He's in Cape Town now.
Oh, is he?
Yes, I saw him there last year, I think. He's got a restaurant. He's got a lot of interest in many things, but not in surgery anyway.
Yes.
And the story about him having, you know, arthritis, that's a news story also, really. He's all right drinking and eating. He's not no more aches and pains than I have, I think. But it's, you know, it's the tragedy of the crippled surgeon sort of thing.
Yes. His brother Marius, is he still in South Africa also?
Yes, he's a politician. He's nothing to do with surgery either.
I see.
He never really was. He was a general practitioner, and Chris made him into a surgeon.
I
Sort of
see.
sent him to Cooley for a couple of months and came back as a heart surgeon. And his heart wasn't in it, and eventually, I think he's given up surgery altogether.
Yes.
Yeah. It was a phenomenon, that, a great excitement.
That was a phenomenon. How many heart transplants did they do at Guy's Hospital? Did you
That
do
was
it?
our first. That was in the heart hospital, and he lived
Oh, in the
3
heart
months.
hospital.
Yes, and then died from multiple pulmonary emboli. And you know, we knew nothing. We used to meet. It was a real pain. We used to meet in the hospital every day, about 20 people, and you can't treat people by a committee, really. And we didn't know anything. We were phoning one another, all DeBakey, Cooley, Barnard, all over the world. And, we didn't know what to do.
Yeah, you didn't know how to evaluate rejection.
We didn't know how to treat it or evaluate it, really. We
Yes.
just had practically nothing. We had steroids and a little Imuran, I think.
Yes.
And, you know, we overreacted, and, you know, and they got infection. Well, it's the old story. And we lost the chap, and everyone else started losing their patients as well. And I made a subconscious decision, we'll try 3. And, you know, that so as to make sure that we were on the right or wrong lines. It was a great disappointment when he died. But the second one we did in the heart hospital was sort of a mistaken. The heart we were using virtually wasn't viable, because there was a tremendous public reaction against transplants, and vitriolic mail and telegrams I used to get, and people threatening and so on. It was really very difficult to get donors at all. The donor we got wasn't suitable.
It was about the donor, the concept of donor death. Was that
That was one
controversy?
concept, but the other was, you know, sort of moral issues and religious issues, and any rent-a-crowd sort of issues. You know, once you're on a bandwagon,
yes,
it's bad. It was
no, I
good.
wasn't aware of that. No, I didn't know that.
Oh, it was always I've got a lot of slides which would shock you if you saw the sort of headlines in the papers on. And so we lost the second one. Then we did the third one in Guy's Hospital, and I decided, you know, and it lasted quite well. By then we knew a lot more, but all of us realized that the excitement was over, and that it's time now to settle down to real science. And so most people gave it up. I certainly gave it up deliberately, and never gone back to it, because now it's in the hands of experts and we know a lot about it. And my colleague Magdi has done more than anyone else in the world, I think, now. There's no point in us playing around with it. But it was an exciting time.
Yeah, it was certainly that.
Mm.
And I think it's sort of tragic that who's to say what would happen to any of us if we became world famous?
Sure, yes.
Yeah.
I don't blame him at all.
Yes.
In fact, I envy him at times. Yeah.
Now, you also were the first, I think, to do a valved conduit.
Valve conduit.
For right ventricular outflow.
Oh, yes, that's 1966.
Yes.
Yes,
Tell me
was
about
a pulmonary. Well, we were very interested in the heart. We had a nice spread of cases, you know, congenital, valve, and coronary. Coronary wasn't flooding the market like those days,
No.
and it was still quite exciting. So we did a lot of congenital work. I was very lucky to have been involved so much in congenital work. And we did a lot of fallows, but this fallow problem became more and more complex as people sent more desperate cases to us, and we found the pulmonary stenosis and the hyperplastic pulmonary vessels and pulmonary hypertension problems, and we didn't have any way of apart from putting in a patch of pericardium, we didn't have any way really of relieving the right ventricle. And there was this funny condition called pulmonary atresia, which was coming to my notice, and there wasn't anything we could do about that, really. Theoretically we could, but we felt we couldn't except that we had this, what was missing was a outflow tract with a valve in it, and we had plenty of those, and so we, one way or another, tried one of these out on a Palmyra atresia, and as usually happens, you know, with the first case, brilliant. We reconstructed the outflow tract, and that was it. I remember there were continuous murmurs afterwards. We thought, that's very funny, it must have a ductus. So we re-explored the basement, but there wasn't a ductus there. It was because of the collaterals, of course. As we now know, you know, if we listen for and hear collaterals, it's probably of atresia. But anyway, that case went very well, and it started. That was the first one. We wrote it up, and it was the beginning of right ventricular reconstruction surgery. It's taken all over the world now, but it's also opened up a whole nest of problems of pulmonary atresia and hyperplastic vessels, and how to deal with them in 1 stage, 2 stages, re-anastomosing the arteries and so on. So it's left me behind, really. It's gone into the pediatric era.
So, but it was an outgrowth of your homograph valve bank, and with the valve conduit. Well, tell me who the other pioneer cardiac surgeons in England and in London at that time in the 1950s and 1960s. Who else? You mentioned Dr. Yacoub.
Yes, well, he was one of our assistants in the Heart Hospital, and very rapidly became a premier man. But when we started off, he wasn't really in the field at that stage. I mean, he's now the premier chap in the whole of Europe, probably. But Lillihei was still a #1 man. Kirkland was a very impressive surgeon. Kirkland, I think, yes, made us all think.
No doubt.
That's I would say, his major contribution. I remember they sent me over from guys to England, to America, to do a sort of a sabbatical 3 months tour, and I went around Kirkland, Lillihei, all the Star, and all the Houston, and a whole lot of them. It was very exciting.
Must have been interesting.
Yes, and because everyone was just developing new things. I remember going to Lillihei's Minneapolis Center, and it was like a circus. Really, I was in the gallery, and there was about 50 people, it looked like, around the table, and pipes and tubes, and people rushing in and rushing out, and they were doing secret work on epsilon aminocaproic acid. That was the secret. And people rushing in and out and not letting you see what it was. And Lillihei coming in they must have started about 8 in the morning or 7 in the morning, Lillihei getting in about 11 o'clock, and he said, "Come down." I went down there. I was so excited, and it was chaos, literally chaos. But of course, the patient did very well, but it was chaos, no question about it. And I thought, golly, I don't know how I can do this sort of surgery. I went from there by bus to the Mayo Clinic. Kirkland was operating. Also, they were big rivals those days, and he was doing open heart surgery, and Lillihei was doing this circus open heart surgery. Like walking into Kirkland's theatre was like walking into a church, a chapel. There wasn't a sound, there was no excitement. We sort of sat in pews watching, and he was, quietly talking, and then the door opened, the heart-lung machine wheeled in like the organ, and connected it up and did the operation, and went out again. And I was amazed. I was just dumbfounded that you could do it, this dramatic thing without too much drama. And so that was a very important lesson for me. And because Brock, my teacher up to that time, was a very noisy, dramatic operator, and Kirkland was sort of cool and calm, and I learned a lot from him in that respect. And going to Cooley, yes, I learned a great deal from him. Technical surgery, he makes things look easy, and because he doesn't mess around. You know, a lot of people sort of fuss around and pick up things and put them down, and I learned from him just to do it. You know? It's an important lesson, that, and he's very fast. I don't know how he is like now at the moment, but he was very fast, everyone realized. It wasn't really because he was in a hurry at all. He just didn't play around. I think that was the biggest lesson I learned there.
Philip Delville told me that one of your interests is keep it simple and keep it speedy and keep it safe. Is that
Yes.
correct? Yes.
That comes from a Indian trainee of mine who works in Madras. He's a very dedicated man, and I admire him very much. I go and visit him there quite often, and he's got a he's got a hospital there of his own, which he runs on a sort of divided basis. Half of it is free, and the other half you pay, and the paying side subsidizes the non-paying. He's a very Christian man, and he's really dedicated to cardiac surgery. He's got a museum
what is his
there.
Name?
Solomon Victor. Solomon Victor.
Yes.
He's made some tremendous contributions. He's got a comparative anatomy museum, which is called the Donald Ross Museum. That wasn't important, but he's made tremendous contributions. And he's very clever with filming and showing the embryological development. And for instance, he's got the hearts of snakes, frogs, fish, elephants, you name it. And he's sort of developed comparative anatomy. And he, apart from the fact, and he's at the same time running a hospital, you see, and his wife is also trained with us at the Heart Hospital. She's now in charge of the AIDS problems in that eastern part of India. But he's got his motto is KISS, keep it simple and safe. that's where I've learned that simple and safe.
That's a very good
concept
motto
from him. Yes.
Well, I reviewed a number of your publications, and so I'll just ask you about some of those. You've had an interest in the anomalies of the coronary arteries. You've written about the primary anomalies of the coronary arteries, the origin of the left coronary artery from the pulmonary artery. What are some of the special things about those anomalies?
Actually, I'm not particularly interested in the coronary, to be honest. I've written about it probably because there was might have been an assistant wanted to. And I know Magdi Yaku was very interested in them in relation to transposition surgery.
Yes.
And I've done this, you know, anomalous origin of the coronary from the pulmonary artery. And
Yes.
I've done some of those operations. I'm interested, but not specifically, not particularly interested. I'm surprised that I wrote an article.
It's a fairly straightforward subject anyway. Let's see then. Well, then at the present time, the indications, I talk about the indications for the pulmonary autograft operation, the Ross procedure. What sort of patient do you think, I would say, we'll think about indications for the Ross procedure, indications for homograph valve, indication for the xenograph valve, and indications for a prosthetic valve. To sort of compare those four procedures.
Yeah, well, I can't see many indications for a prosthetic valve.
Yes.
Myself. It's not a prejudice, but
Yes.
I can't see it because they're so abnormal, from my point of view, they're rigid. You know, they have to be in order to, I'm not denigrating them at all. I mean, they've saved millions of lives, thousands of lives. But as an ideal valve, they're not ideal to me in any sense of the word, in that they have to be rigid in order to accommodate their various discs and flaps and balls and things. And so that once you put a rigid ring into a contractile orifice, like the aortic or the mitral orifice, you splint a good deal of viable muscle in doing so. And if you just put a ring in without any ball or disc or anything else into a flowing orifice, you get an obstructive gradient.
Yes.
Without having to put anything obstructive in. So you have this rigid thing which splints the muscle, you create a gradient, and in addition you have obstructions causing turbulence, and well, this is, everyone knows it, and it's as a result of that, of course, you have to give anticoagulants, which is another sort of Damocles sticking in your back virtually. So I haven't got much time for. We've put in a lot of mechanical valves in the past, and of course you've got to train people how to do it, and in emergency situations, of course, we wouldn't hesitate to use it where there was nothing else. But it doesn't appeal to me in any way, any form. The other, so I'm a biological valve man. The other biological valve, of course, is the bioprosthesis, which is a good name because it's not really a biological valve. It's halfway between the two. You have a mounting ring and a biological valve inside. The biological valve is good in that it's centrally flowing and non-obstructive in itself, but the mounting ring is usually very bulky. And so you get some of the advantages of the biological valve and some of the disadvantages. You get some of the advantages of the mechanical valve. It's easy to sew it in from a I always say the mechanical valve was built with the surgeon in mind, not the patient.
That's good.
You take it off the shelf, sew it in, and go off and play golf. You see? Don't have to fuss around about it. So I think it's a compromise between the true biological valve, which is a homograft or an autograft, and the mechanical valve, which is, and it's an uneasy compromise. And it's okay if you want to say I put in a biological valve, and you get less instance embolism on it, but you haven't really got the advantages of the homograft, we'll say. But the disadvantage of the homograft, of course, is it doesn't last forever. And so that's, you come to indications when you're going to use the homograft. You're not going to use the homograft these days in children, for instance. And if you reckon that the homograft's going to last 15 years, if you're lucky, that you should regard that as one of the criteria you'd use when you're deciding whether you'd operate on somebody. If you're dealing with somebody about 70, you say, well, why put in autograft? Because, it's a long and more traumatic operation. Homograft's going to last you your time because, in any case, as you get older, the rate of tissue failure in homografts slows down, and in xenografts as well. So that if you're 70 and you need a valve homograft, a quick, convenient operation, I would say that's an indication for a homograft. When I introduced the autograft valve, we thought clearly defined criteria, which should be a young person with at least 20 to 30 years of life ahead of them. And you knew that wasn't going to be any good, homograft wasn't going to be any good for that. And so we thought people around about the age of 20 to 30, now people live longer still again, but around about the 30-year-old was the ideal age for the autograft operation. That's how we were, and that's still, if you look at the instance of the cases I've done, it's always peaked around about 30. We tried a few in youngsters to sort of exploring the limits of the operation. We went up as far as 60, I think, but we still said, and I think still say, that the ideal valve indication for the autografts is around a young person, around about 30. But now, of course, that was when before the operation was a success and accepted. Now, of course, I'm amazed and astounded and impressed to find they're doing it in one-day-old children. In Austin, at an audiovisual meeting earlier this year, they told me about the surgeon there who they diagnosed aortic stenosis in a newborn unborn baby with transfetal echocardiography. And so as soon as it was born, that day, they took it and put in an autograft. That's pushing things, I must say. But successfully.
That is pushing it, right.
Successfully. I mean, I can't, suggest that this is a good way of doing it, because I think you have the problem of the right ventricular outflow tract, which you know is going to be small, and you put in a small homograft, you're going to have to replace it in a year or 2, or maybe 3. And so I think it's very clever, but not necessarily the best indication for a home. And similarly, I've been told that people of 72 are being, or later now, having autografts done. And I think Jim Uri told me about somebody of 60 or something, 65, who needed and Jim said, we can do a homograph for you. And he said, what do you mean homograph? I want an autograph. I don't want to have my valve changed every 20 years. So I think that's, that's interesting. But I mean, I think that autograph's a wonderful valve. I didn't invent it, but it can now cover the whole spectrum, you understand?
Yes.
But I mean, I think older patients, yes, and older than that, perhaps a xenograft is fine. I mean, you've got to, they say horses for courses, you've got to match your patient to your what you've got and what you think he needs. It doesn't apply to everyone the same, doesn't apply. Some people at 40 are old and some people at 80 are young.
As far as technique is concerned, do you think things are moving towards root replacement?
Oh yes, everyone uses
far
root
simpler
replacement.
procedure.
Much simpler, and you can guarantee a competent valve. I mean,
yes.
The first 271, I think, autografts, I used subcoronary insertion. Still a great operation, and I think Magni's doing one tomorrow, or a homograph subcoronary. And if you know how to do it,
Requires a lot of judgment.
but you have to learn how to do it properly, and most people don't have the competence or the patience, and they condemn the operation. They did that with the homograph. They all took it up and then said, "Oh, it's no good, they leak." It's their fault, not the valve's fault, really. But yes, and the root is easy to do, but now there's hazards there because people are putting the roots in wrongly, in my view, because there's now criticism coming out saying, the root's starting to dilate and leak. And in every meeting like this, you'll hear people talking about it, grumbling about it, saying how to prevent it. Well, the problem is you cut the aorta in half, you take the valve out of the valve bed, which is surrounded by left ventricular outflow tract muscle and the fibrous tissue of the mitral valve, and it's firmly fixed in there and supported, because the valve itself doesn't have any strength. The ring is just a sort of fibrous thickening. It's not any strength like the pulmonary valve, no strength in it itself. But they cut the aorta in half, take the valve out, and then the easiest thing, of course, is to sew this autograft in with interrupted sutures, with continuous suture, which I don't think is a good idea. They sew it in quickly as a continuous suture line to the segment of the vessel of the heart above the natural aortic line of insertion, which is unsupported virtually. Or you can sew it to the cut edge of the aorta, it's even worse, totally unsupported. So when you apply a systemic pressure to that, it starts dilating. And again, people say, oh, the autograft's not such a good operation, they leak and so on. But again, we're unable to look into ourselves, really, and blame the operation rather than our techniques. And I think that's the commonest cause. There are other causes, of course. I mean, the aortic root is a very interesting part of the body, I think, and you've got all sorts of difficult diseases. They're ill understood often, not Marfan. Marfan we understand, and of course we wouldn't use an autograft in Marfan. But there's related to ankylosing spondylitis, there's aortic root lesions, there's, I'm trying to think the name of lupus erythema. There are lots of ill understood lesions of the aortic root, and if you're in doubt, you shouldn't do it, because there's an inborn tendency to dilate. You get aortic root aneurysms from some of these conditions. And I keep saying people should do a biopsy when they do the aortic root, but they never do, of course. But I think intrinsically it's an excellent operation. It's a good operation. There's no reason why it should fail.
Yes, you think the mortality, the mortality for it's a big operation, of course, and it involves two
and
valves.
a surprisingly low mortality considering
yes. That's what I was going to ask you. The reasons for that. The reasons that the initially, when in the 60s, of course, mortality for all cardiac surgery was much higher. The average mortality has come way down. In this particular procedure, what is the principal cause, you think, of the reduced and the low mortality? Jim Howery told me that he'd done his 100th Ross procedure without a death. It's
amazing,
astonishing.
Isn't it?
15 years ago, you would say that would not really be possible.
I remember Magoon in the Mayo Clinic doing 100 aortic valve operations without a death.
I remember that, yes.
But that's because he was a trained surgeon, he was a professional, and that's why Uri's case are doing so well. Everyone's doing well with the autograft. Strangely enough, to me it's strange because it is a long procedure. There's no question about it.
Yes.
But the advances in bypass work are so great that time isn't really a factor anymore. It's technique.
Yes.
And the other thing is, of course, you're putting a normal valve in a normal valve in. I mean, the heart jumps with joy. There's no doubt that the initial response of the patient to the autograft operation is dramatic. And Jim's got patients with who are doing, broncho busting and reliability rides and all sorts of things with an autograft in. I had an Israeli soldier who was a physical training instructor, and that's really tough life in the Israeli army. And he's had his autograft. He's doing back at it again. It is remarkable. The heart likes to have a normal valve, I guess.
Yes. One of the things that's trendy now in cardiac surgery is minimally invasive. What do you think? Do you think is that here to stay? What do you think about minimally invasive coronary surgery and valve surgery?
It's a gimmick.
A gimmick.
Well, maybe I'm just too old. But I don't think it's basically necessary. I was brought up with the view that you should see what you're doing. See clearly what you're doing. Now, you could say, well, these incisions are too big and so on. I agree. They probably are. And there are indications. I mean, if you've just got an LAD lesion and it's just over there, and well, okay, or don't use a bypass. There are indications for it, but I think some of the putting aortic valves in through little portholes here.
Heart port.
Yes, a bit much. Well, I don't want to sound fuddy-duddy, but I don't need it
Well,
myself.
of course, I agree with you, so it sounds good to me.
Yeah. Yes, I think it's a phase. I hope so.
Yes.
But people are getting bored, especially with their coronary surgery, which is a dull surgery. I don't like it.
Yes.
And so they're thinking up new ways of getting around it. And doing mitral valves through little tubes, I don't feel that's the right thing either. You see, we're taken to putting, if you don't mind me changing the subject a moment, the autograft. When I first described the autograft operation, I said for aortic and mitral valve disease. People don't seem to remember that. And it was in the Lancet and pictures of how you could take this valve, pulmonary valve out and put it in the aortic position or in the mitral position. And we did about 8 pulmonary autografts in the mitral position, putting them in a Dacron tube and putting them in the mitral. And really, got so tied up with the aortic replacement and the problems associated with that, we sort of left the mitral problem alone and just started putting in homographs on stents in the mitral position, easier, quicker, and we felt we were doing the right thing. But now since ACCAR, we also tried putting mitral homographs in, and I had a lot of trouble with that and gave it up. We got ruptured cordae and so on. But now since this chap ACCAR in Paris has come up with the mitral homograft successes, and Jim's had them here, he's doing one on Friday, I think, we thought to re-evaluate the question of the autograft in the mitral position. And I looked into these first 8 patients that we did in 1967, and it's very difficult to get because 30-year follow-up, you can't get you don't know what's happened to people. They scattered all over the world and died and whatnot. But we found one that I'd operated on 14 years afterwards for endocarditis, and the valve looked fine except that it had a hole through it. I should have just patched it, but I took it out. We found that there was another one, a young lady that I'd done, I think, at the age of 11, who now had a baby, and 14 years later, also 14 years later, we had a letter from her saying she was changing hospitals and could be referred to another cardiologist and so on. So that was interesting to find 2 patients in that first group 14 years later, and then we now discovered that one at 10.5 years got endocarditis, and somebody else at 10 years was seen, hasn't been seen again, and one has, the others have just, you can't get follow-up at all. You know, they've vanished out of, in a big country, a huge population country, and don't know where they've gone. But that gave you room to think that why do we go on struggling with things that perhaps we could put in a autograft valve in the mitral again and get a permanent valve there, especially for children. So
be fantastic, yeah.
Well, so we started. 2 months ago, I've got a colleague in Syria. I go to Syria often and operate. He's very interested in the mitral problem. We've been trying mitral homograft. So we've started doing the autograft in a top hat in the mitral position. We've done 8 now, and they're doing fine.
Now, tell me about that. That's the pulmonary valve,
Yes.
mounted in a
Just
flexible,
a tube of Dacron.
yeah, flexible tube. And then what sort of a suture line? Is it a single suture line or?
Yes, to the
Yeah.
aorta, to the mitral ring. Yes,
Yes.
single suture line, and it pops up into the atrium, and you put a top hat on that now. You put a piece of pericardium. You put a new floor in the atrium. I think that's got great potential, and I'll probably say a word about it at this meeting, because we've come back to it. You see.
Yes.
And it's really been neglected all this time. But it's logical to have a living valve. I mean, I'd rather have a living autograft in the, a living autograft tricuspid valve. We've toyed with the idea, this man in Syria and myself started off saying, well, we're going to have to take the tricuspid valve out. Well, that's difficult.
It's very difficult.
We've been playing with that. And don't say it's impossible, but everything's possible eventually. But as a compromise, we're using the pulmonary autograft in the mitral position. You take the pulmonary out, hand it to your assistant. You take the mitral out, and then you take out the pulmonary valve, hand it to your assistant, who fixes it in this Dacron tube.
With a two layer, just like it was.
That's right.
Would be a.
That's right. And while you're repairing the outflow tract, he's getting that ready, and then he gives it to you. You put it in. It's quite a neat operation.
But I don't understand about the pericardium. The purpose of the pericardium.
Oh, to put a new floor in, because this thing stands up proudly into the left atrium, but it plunges, you see. So you just put a top hat on. That my colleague Magdi gave it the name top hat. And pericardium or Dacron or whatever you like.
Yes.
And it stabilizes there and gives you a new floor.
Yes.
And so I think that's...
And so it actually has sort of a 2-suture line then.
Yes.
It has the annulus.
That's right, to the annulus, and then it pops up and you put that, you just attach that to the adjacent atrial wall.
Yes. That's so interesting, yeah.
So he's very enthusiastic about it, and He was doing another one yesterday, I believe. I haven't heard. But yes, I enjoy Syria, incidentally. That's a very interesting part of the world. I go to Egypt. I've been operating in Egypt for the last 20 years with a team. We take every year and have a great time. And I go to Nairobi, Kenya, and operate there. I like moving around and introducing surgery to these people. Not cynical, they're all very
Well, I'm sure they're
grateful.
grateful too.
Yeah.
Well, my final question then, I wanted to ask you, assume that we're talking to a group of young surgeons who are considering cardiac surgery as a career. What sort of prospects and advice do you have for that group?
You know, I always say to people, if you want to do it, do it. I mean, I can't persuade you to, or I don't want to persuade you to. You've got to have conviction. You've got to want to do it. If you want to do it, do it. I mean, I've known young women, it's very difficult to get into surgery as a woman, really. It used to be, it's less so now. Who'd say, you know, well, I would love to do, say, cardiac surgery, but how can I do it? I say, do it. And that's all I would say. You've got to have the conviction and the belief in what you're doing, and it doesn't matter. I haven't got any better advice than that, just to get on and do it.
Well, that's good advice. And thank you so much for sharing your thoughts and your memories and the information about the past of cardiac surgery. And I know they'll enjoy hearing about it tomorrow at the meeting.
Thank you. Thank you,
So,
sir.